This is the ad in 1975 that used a prepubescent Brooke Shields to sell Calvin Klein jeans. It went along with a tagline, "Nothing comes between me and my Calvins." We see this sort of thing not infrequently. This is a record album cover featuring a somewhat alluring young girl. This is a shampoo ad, perhaps an innocent one. This is another record album presentation of a child. This is actually from a marketing trade publication. How old is this glamorous model? Would you believe 13? And here are the people who read this particular commercial literature are interested in what it is that they can use to sell commercial products. And here the allure of children is presented as one way to do this. This is an ad for quite a legitimate commercial product. Chanel No. 5, a rather expensive layout in a women's magazine that poses an ambiguous message. Here you can see the Chanel No. 5 label, tiny treasures. What the ad stimulates one to think is the tiny treasure. Is it the expensive vessel in which the perfume is sold? Is it the little girl? Is it some part of the girl's body? What's going on here? Well, here the advertiser is attempting to use, in the time-honored techniques of advertising, the stimulating and pleasurable arousal that this picture stimulates. So the next time that we were to see that commercial product on a shelf and are contemplating which perfume to buy, those feelings, that sense of arousal will be associated with that product. Now, it's not a far descent from this to here an April '76 Playboy magazine cover, and you can be sure that the folks who decide what goes on the cover of Playboy have a good sense of what it is that may sell. Here you can see a sexually mature woman, but gotten out like a preschooler on a potty. Here as well, if you will, the sexualized allure of children are being used to pull attention to the magazine. Also, since I've talked about politics so much, about which I apologize, but I think it's unavoidable in this season and this topic, I just want to point out that Playboy magazine also featured a startling interview with the enigmatic young governor of California, Jerry Brown. No longer on the political landscape, but still an enigma. Now, as well, we have in this country a several billion-dollar industry involving pornography, much of which involves children, and much of which involves a convergence of sexually stimulating and provocative themes with artifacts of violence. And here you can see the cadaverous representation of a child in a pornographic magazine, deathly tones, genitals prominently displayed. Many people who fancy this sort of stuff are quite stimulated by this kind of material. And here, and there's a pediatric take-home message to this particular one, is another child, a preschooler, in a pornographic magazine holding what appears to be a vibrator. And you don't have to be an expert on child sexual victimization. I think my colleague Andrea Van Dieven would agree to see that it appears as if this child's vaginal and anal openings were instrumented. Now, there's a particular reason that I wanted to show you this particular picture. Actually, there are two reasons. First, to point out that most pedophiles, adults who are sexually oriented toward children, have in view both a particular age window of childhood and a particular gender of child. But if kids aren't available to them to exploit, they will often resort to pornography or to memorabilia of their own experiences with children in order to nourish fantasy. And this is why it's very important when you see a case of child abuse, child sexual abuse, always to ask if pictures were taken. Very frequently the pictures have indeed been taken, and if you find out about them, you can report that. Just want to point out that in the McMartin preschool case, the longest-running criminal case in American history in Manhattan Beach, California, had the pediatricians who initially heard the disclosures of the children's victimizations at that daycare center thought to ask, were pictures taken? Had they thought to pose that question, search warrants would have been obtained, and the children and families would not have been put through the awful ordeal of that criminal trial. And some of you may know that the mother of the first child who disclosed that child's, who then reported her child's disclosure of his victimization to her, committed suicide in the course of this long-running and very hurtful criminal inquiry. and process. Had the pediatricians been alert, conceivably, that may have been avoided. Now, I want to also just note how very frequently pornography also assembles glorified images and text about incestuous relationships with provocative images of children. And very frequently, the child pornography also features hurtful impositions on children, violent stories of brutal incest, S&M and the American Father, daughter's torment, runaway teen slaves obviously being hurt. Now, as well, much of the adult pornography, I perhaps need not ram this issue home so forcefully, but I think it needs to be said, also features suffering and pain on behalf of the victims. Now, I point this out to you because I think this is part of the landscape in which our work on child abuse needs to be embedded. It obviously poses contradictory messages to parents and to others as we do what we can to allay the suffering of victims. But I think it's also well to point out that our own personal reactions to this material may differ. Women, seeing images of this kind, are most often horrified and dismayed and revulsed by material of the kind that I've just shown you. Men's responses, the studies of responses to pornography seem rather uniformly to demonstrate, are somewhat more muted and are often responses of interest and sometimes of, or certainly more frequently, of arousal. And I think that this goes fundamentally to the core of an issue with which we pediatricians, I think, must be concerned, and it concerns our socialization about sex, about sexuality, and most especially about women, but obviously as well with regard to children. This is an important frontier, it seems to me, with which we need to contend as we use the good offices of our profession to promote a better and safer context for American children. This is from the Boston Globe. He's saying to his child, "If I catch you watching violence again, I'll knock your block off." You got that? The average American child between the ages of 5 and 15 witnesses the killing of over 13,000 persons on television. Let me repeat that. The average American child between the ages of 5 and 15 witnesses the killing of over 13,000 persons on television when you figure what it is that kids watch on the tube and how much time they spend in front of it. There's no question now that this models aggression on the part of kids, most especially of boys, and it also encourages a tolerance of aggression. There's some reason to suggest that it may also affect parental behavior. He's saying to his child, "I'm asking you nicely, but I'm not ruling out the use of force." Now, this charming New Yorker representation of parent-child relationships is kind of precious and nice, but it brings in a humorous way to the fore an issue with which I think we pediatricians need to begin to contend, and that is our, how to put it, negatively or positively? I'll put it negatively. We need to contend directly with our timidity in the face of the wide acceptance of corporal punishment in the society. Some of you may have seen the special issue that the JAMA devoted to family violence a month and a half ago. In there was an article about physicians' approval of corporal punishment, and the prevalence of approval was dismayingly high. There's no reason for it. It's associated with child abuse and other forms of family violence in most of the studies looking at family factors. Now, I want to turn briefly to the subject of battered women, and then I'm going to close because it's part of our current practice landscape, and I just want to mention it in this way. He's saying to her during the next commercial, "I'm going to belt you one," raising the question, of course, whether the media is protecting her, at least for a moment. And here you see a man saying to his spouse, "How would you like a household injury?" Now, this connects back to that earlier case, the first case that I showed you, where there was a concern about whether to characterize the child's injury as an accident as opposed to abuse. In fact, most battered women, when they seek urgent care for their injuries, have their injuries characterized as accidental or as household injuries. We surely found this in the study we conducted for Robert Wood Johnson Foundation in the emergency room sites when we spoke to physicians and others there and spoke to battered women's advocates and others who are knowledgeable from the battered women's perspectives about the responses that they received when they sought consultation. This is a big problem. Just as with child abuse, we need to begin systematically asking women who are injured about their injuries and then do something to help. Here at Children's Hospital, I'm proud to say, we've had since 1986 a model battered women's advocacy project that's based in our social service department, housed over in Gardner House on the 8th floor in my unit. Marvelous project called Awake. We have available here 2 battered women's advocates and supervisory staff. When you see a case where you think the woman may be battered, you've got access to help and ready liaison to battered women's services. Ours was the first hospital in the country to start programs like this. There are now 2 others. Finally, a couple of quick cartoons and one more teaching message, and then we'll stop. This is from the Boston Sunday Globe. Georgie belted me, it's the Smith family, pulled my hair, stomped me, slugged me, made my tooth wiggly, gouged my eye. Georgie, why did you do all that? She shredded me too. We were playing a game. What game? Marriage. Well, in this era of concern about family values, obviously there's a lot of lampooning of the family, but here there's also a serious take-home message for the pediatrician. There's little question now that children who were exposed to their mothers being beaten are themselves likely to have important responses to that victimization. And the few psychiatric studies that we have, which to me are quite compelling, suggest that boys particularly, in the face of what the students of this phenomenon characterize as the powerlessness that children feel in the face of their mothers being beaten, will very often respond with aggressive responses or with aggressive actions and play with other children, and indeed, the data would suggest, with later aggression toward other children, as they try to make themselves feel more powerful and take superordinate roles and sometimes hurtful postures vis-a-vis other children. And so when you see a child where the complaint is aggression, think to ask about the woman's possible victimization. And if you're here at Children's Hospital, obviously you have good tools to act on it. Now, just a couple of things about battered women, and this pertains in a way to pediatrics. A few months ago, this arrived in the mail. You can see my hospital mailing label here. I don't know which mailing list this was from, but I subsequently found out that this was mailed to all members of the American Academy of Pediatrics in the state. And it was a magazine that came along with a letter saying that if you want a free subscription for your waiting room for this magazine, you can have it. And I looked through it, and it was lots of nice photo portrayals and a bit of cheesecake. But here in this magazine for the waiting room was this artful picture of a spousal relationship. Now, I want you to know, I called the firm that sent this material out, which was doing a promotional job for this particular magazine. I also made contact with Tony Novella, the Surgeon General, the chair of the AMA's Family Violence Committee, and the American Academy of Pediatrics, and I'm happy to say that they pulled the promotion. My message, however, to you is obvious. These images are insidious. They obviously can telegraph an involvement by medicine with these problems, which is highly problematic. Now, in conclusion, let me just briefly say that there's a great deal that we as individual practitioners can do, but clearly we need to operate as well on the larger context of violence and sexual exploitation in our society. We as individuals, we as a profession, have an obligation obviously to allay the suffering of individuals, but in my view, we also need to contend with some very problematic values in our society, and indeed to become more courageous and forthright in addressing some of these issues. And my final slide puts this in somewhat humorous terms. This is my favorite slide, I got to tell you, but it kind of captures that message in a lovely way. Here you see the tragic ending of a play on the order of Othello, with a Desdemona figure lying stabbed on the bed, Othello weeping, bloody sword in hand at the foot of the bed, and then prominently in the foreground you can see a dowager who is saying to her consort, "What a shame, with a little professional help early on, all of this could have been avoided." Thank you very much.
Dr. Newberger, thank you very much. We have time for maybe a question or two. If you'll please use a microphone.
What can practicing pediatricians do to prevent this from happening? What kind of anticipatory guidance or whatever can we do?
Lovely question. In brief, there's a great deal that one can do. In conversations with families beginning at the time that a child was born, and the experience of Dr. Peter Stringham at East Boston Health Center has brought this out very nicely. Parents can and should be asked about how they propose to deal with problems and conflicts with their child, and that provides an early opportunity for the parents to talk about their own expectations, their own experiences, and for engaging with them in discussion about them, about these experiences. My feeling is that early on it's well to consider the proscription of any violence in family relationships. That's one thing that can be done. Another thing, it seems to me, that pediatricians must increasingly become able to do, but here our practice is somewhat confined by the constricted nature of our reimbursement systems, is to make sure that parents understand that at times when they are in distress about issues involving the behavior of their children, that the door is open to discuss that with you. And in so many of the cases of child abuse, child physical abuse especially, and the tragedy which led us to set up this Grand Rounds is a vivid current example. Had that door been open, had the parents been able to share some of their anguish about the care, in this case, of a young infant, tragedy could have been prevented. So very many of the child physical abuse cases are isolated, occur in isolated families. We did two large epidemiological studies in the 1970s looking for key risk factors in child abuse, failure to thrive accidents, and poisonings. In the first study that we did, the most salient attribute in the discriminant function analysis in which we looked for the most important risk factors was child abuse, for child abuse, was the absence of a telephone, a vivid artifact of social isolation. And I think that pediatricians can work to relieving that isolation. Now, as well, obviously, we have a terrible problem with regard to access to pediatric care in this country. Incidentally, I got to say, Hillary Clinton was marvelous 2 weeks ago today at a fundraiser lunch here in Boston. She's got a very good handle on these issues. And this issue of the isolation of American families is of particular interest to her. I'm not telling you who to vote for, folks, but I was really quite heartened by it. Go ahead, Cedric. Sorry.
Okay, well, thank you very much.
You're welcome.